Good afternoon. Oh, yes, I did. Thank you. Hi, everyone. Welcome to our session today. My name's Heidi Steiner, and I'm a clinical program manager for Caregility. And I am joined here with Dr. Deb Marineri. And Deb, why don't you give a short intro, and then we'll get right into our questions.
Great, thank you. As Heidi said, I am Dr. Deb Marineri. I'm the Associate Vice President at Hospital Operations for Stafford Hospital, but I am a nurse. I'm a DNP nurse. I like to usually say that first, so I apologize, but I'm a nurse first, but I oversee hospital operations for Mary Washington Healthcare at our Stafford campus. Just for a little background, we are a two-hospital system, so we have a bigger hospital named Mary Washington that's a 471-bed hospital, and then Stafford's a community hospital, about 100 beds, just to give you some context of where we're starting with the organization. But pleasure to be here, and can't wait to go over our journey into virtual nursing.
So I think virtual nursing is one of the hottest topics right now in healthcare. So we are just thrilled to be able to partner with Mary Washington to launch a virtual nursing program. And I've been working very closely with the team. Deb has a fantastic team, and they are just doing a fantastic job. So real excited for her to share with you this afternoon. So the first thing I wanted to talk about was your journey to virtual care. You've had tele-ICU for quite some time. In Mary Washington, you have telesitting, and you're now embarking on this journey to support nurses through virtual nursing. And your organization is recognizing the value of streamlining care delivery in your system and really wanting that seamless experience for patients and clinicians throughout your system and then into the continuum of care at some point. Can you give our audience some background and insight into what led you to believe that now is the time to launch a virtual nursing program at Mary Washington Healthcare?
I think the first thing was I had to take a step back and say, the definition of insanity is keep doing the same things and expecting different results. And we were just at the point where we just couldn't keep the care delivery model that we had, just was not sustainable. And we're as I'm sure you've heard other speakers and your own organizations, it was a very similar story. We were having just such a high nurse turnover rate. It was embarrassing to the point, just that constant churn of nurses, lacking staff engagement. So of course we had higher than normal nurse to patient ratios. So then in came the onslaught of all the travelers, the agency nurses that we had to use. And not that agency is a bad word, but it's very expensive. So then we came into the financial crisis that just a lot of constraints come with high labor cost. And so luckily, I was actually in my DNP program at Baylor University, so go Bears. And I came up with the idea after doing some research about what other organization was out there, because as Heidi said, we had already tapped into the virtual market, but we hadn't done anything for the inpatient team. So the medical team, the surgical teams, the cardiac teams. So I did some research, looked what was out there, and proposed maybe we need to go further virtually and do it more on the inpatient side. Luckily, my executive team was very much on board, was intrigued by it, and said, yeah, maybe this is a new care delivery model, because again, it was just not sustainable anymore. And so proposed and got it approved, and I'm happy to say that we're very much in the very beginning phase, because we're actually installing the cameras next week in the patient rooms, but we're there at the tip, and we're just so excited to be starting this new phase of care for our nursing staff, and of course, safer outcomes for our patients as well.
Thank you. Very exciting. So my background is actually in informatics. So I've been helping organizations use technology for many, many years. And I know that in that experience, if clinicians don't see the value in that technology, they won't use it. If the technology is hard to use, they won't use it. So talk about the goal of consistent care delivery in Mary Washington, and your organization. It really does have that strategy to put a camera in every room to support this so that the technology is there and it's easy to use. Can you explain what this initial phase of virtual nursing looks like at Mary Washington? And knowing, of course, you're still early in your journey, what has been the biggest challenge so far?
Yeah, so interesting enough, we did a proof of concept for virtual care because we wanted to make sure, where was this going to take us? Because with technology, you have to have a return on investment. It's a big investment. So we, last year, around this time, introduced virtual nursing for the one unit, just to kind of see how it would go and just see how the nurses reacted, the whole clinical team, the physicians. And so we did the concept of using iPads. We're an Epic hospital and Mary Washington Healthcare. So we had iPads in every room already to use for MyChart bedside. So we did that trial with a virtual nurse being our own nurses. We have a telephone triage nurses because we didn't want to spend any more money. It was a bad situation. We couldn't afford to do anything too much, especially if we didn't know if that was the way we were going to keep going or not. So we did the proof of concept, and at first it was a hard buy-in because the nurses was like, really? What are you I mean, that's my job. Why are you doing this? I can do this. But they were struggling. They were frustrated. So once we got get that first change management, why the whys, we want to try this, and got through some of those hurdles. The iPads, which worked fine, they're, great technology, but they were limited, and it caused us still to have another resource in the room to help the patient. Had to provision the tablet. You had to make sure it was, battery was good, was in front of the patient so that virtual nurse could see the patient. So they were like a little frustrated at first, like, well, I might as well, again, just do this myself if I'm going to have to be in the room or spend more time with the patient. So, but we continued on. We got it hardwired. We got it working well. And then before the proof of concept was over towards the end, then the nurses was like, wait a minute, where did all these virtual nurses go? We could use this because they did see the benefit. They saw that the time that they knew that nurse was in there with the patient, they could go do other things. They could spend more time with the patient, doing the wound care or giving medications and really explaining what was going on, the plan. So it was interesting towards the end, that change, that gradual change. But that frustration really stuck out for me. And I think that's why I was very much a proponent of putting a camera in every room, because I didn't want to add additional frustration to the bedside care team. So that way they didn't have to worry about the technology. It would be there, can come in, and they wouldn't have to have that extra support that was a little daunting for them during the proof of concept.
Great, thank you. So we're going to talk about KPIs and what sort of led to your KPIs at your organization. But to sort of set that stage, healthcare, it is a fact that we design systems, and we get the outcomes for the systems that we design. So one of my passions for my entire career has been in how do we really educate patients in a way they understand, and if it's not the patient, who is it that we should be educating to really move that needle? And then also in the acute care setting, what is the right education to offer to patients, knowing that they're there a short time, they're sick. So it's no surprise that when we don't engage with the patients in a way they understand, we don't keep it simple, that they go home and end up back in the hospital, and we wonder why we have readmissions, we wonder why those discharges are delayed, we wonder why patients feel like we don't communicate with them and our patient satisfaction scores aren't where maybe they need to be. So one of the reasons I'm so excited and passionate about virtual nursing, in addition to everything that we talked about, is the opportunity to finally focus some time on patient education and discharge preparation while in the hospital. And that really was my focus of the DMP project, was how do we teach clinicians to do that quality interaction, overcoming low health literacy, using TeachBack. And the problem is that it doesn't matter if you train the whole hospital on how to do that if they don't have the time, or they don't have if we haven't supported a system that can support that, then they're not going to be able to do it. So with the virtual nurse, that's just one of the KPIs that I'm most interested in following. And just to give other examples of KPIs that we've seen in the industry, Atrium Health implemented virtual nursing during COVID, and they saved the nurses 2 hours each day because they weren't putting on the isolation equipment to go into the rooms. They also saw 56% reduction in the number of call bell responses after they implemented the virtual nursing program. So having said all of that, I have a 3-part question. What KPIs did you and your team define? Can you take us through some of the key conversations that led to the virtual nursing program KPIs? And finally, how do you plan to measure both pre and post metrics? So let's start with the KPIs that you have defined.
Great, Heidi. Yeah, you did a nice summary though, because it was key to define our key performance indicators that would align to not only our mission and our goal of the organization, but we had to, it had to be a return on the investment, like I mentioned earlier. If we're going to invest in this technology and this new care delivery model, we wanted to make sure. So our executive team worked closely together to make sure that they understood what they knew that they were going to see from this, investment. So some of them were the basics, like we kind of already said at the beginning, was patient engagement, nurse engagement, patient satisfaction, decrease in nurse turnover for sure, watching that turnover rate. We're also going to monitor the decrease in traveler or agency use, and then quality and safety metrics, such as we want to focus on falls with injuries, hospital-acquired pressure injuries, and then anything hospital-acquired infections. So, making sure central lines or catheter-associated urinary tract infections, all those things, because we expect that virtual nurse to be a part of the care team, augment the care team, and be there with the nurse in the room at all times, when they need them, when the nurse needs that help. So we actually definitely are expecting to see a decrease in all those metrics, and also readmissions, which Heidi alluded to at the beginning. We do already do a triad discharge, where it's the patient, the nurse, and the physician in the room at the time of discharge. And that can cause some delays, because sometimes when the nurse is ready, the physician's not ready, or vice versa. So with the help of the virtual nurse during the discharge, they can all be together. They can kind of plan ahead, where that nurse won't be pulled into another room. The virtual nurse can plan ahead and make sure she or he is ready to do that discharge with the physician in the room. So we're really excited about that, because we know that virtual nurse can spend that extra time that sometimes we're rushed as clinicians to do now, and give that thorough detail, make sure all the I's, are dotted and the T's are crossed at discharge. But those are mainly a lot of the key performance indicators to start with. And I'm sure we're going to make sure we have the pre-data, and then of course measure throughout the whole. When we go implementation, in May, we'll make sure we keep following those closely.
And one of the really great ideas the team had when we were going through workflow design was, during that triad discharge, the virtual nurse is going to bring the AVS, the summary up on the screen, so that as they go through, if there's changes or if it's not accurate before we print it and give it to the patient, that they make sure that that AVS in the summary for the patient to take home is accurate, the medication list is right. And I thought that was just a phenomenal idea that they came up with. So, finding the right fit for any position is worth its weight in gold, especially a new position, when you're creating new positions, and especially in healthcare. Every nurse may not be a good fit for virtual nursing. And I have been working very closely with the operational leader that Deb has put on the virtual nursing program at Mary Washington, and I can't say enough about this person. Her name's Miranda, but she is just a great leader, and I'm going to have Deb sort of tell us what qualities she was looking for when selecting an operational leader for the virtual nursing program. And then sort of along with that, the job description for the virtual nurse. What were some of the discussions you had with your team, and what kind of competencies did you look for, and how are you going about the interview process?
Great, thank you. Yeah, Miranda, again, Carol Agility has been a great partner, and definitely appreciate Heidi's help at the table as we work through the workflows and such. But yeah, I definitely knew anything with this big a change in this magnitude, you really have to have somebody that's really is a change agent. And as soon as she came in to start working for me, and this project was evolving, I could just tell she was the right fit. And as you know, you got to be that transformational person. But she got it from the beginning. She was recently just from the bedside, so she knows what some of the struggles are, and what a nurse faces on a daily basis. So it was just really nice for her. She picked it up. She had the positive, the energy. She got the team really quickly all on the same page, and got them engaged enough so that they all wanted to work together. And of course, being a 2-hospital system, we do have our other hospital that's, at the table with us. So she also has to be very good at navigating, because what's good for the bigger hospital may not be as good for the smaller hospital. So just taking control of that and make sure that the workflows are done, thinking about both hospitals and both needs. So that's been great. She's been right now, as I said, we're not quite live yet, but very, very soon, but in the interviewing stage right now. So we're just looking for, of course, the experience level is huge for these nurses. They have to come with the right background and experience, of course, but they're also making sure that they are good, because you're going to be in front of a camera, not real in person, and just making sure they have those skill sets, talking into it, being comfortable, using the technology and the monitoring and being able to prioritize patient care. So that's what we're basing our questions around, because we already know they're a nurse. Now we want to know how they're going to fit into this. And so we're doing a neat little exercise, which, I'm sure other hospitals will probably be doing as well, but just making them actually walk through how to do something over, isolate it. We put them in another room, do a Teams call, and they actually have to describe how they would walk the patient or the nurse through that as part of the interview process. And that really helps us kind of weed out who you think is going to be a better fit. So it's been a learn as we go, and we know we will, pivot as throughout the process, but we're excited.
Yeah, I think that's a great idea. Love that. Again, as an informatics professional and change agent, change is hard, especially in healthcare. And technology is only as good as the workflows that we have to use them. So if you can have the greatest technology, and I think we already talked about this a little bit, but unless you have the workflows to support it, you're not going to see the value. So I have up on the screen the first set of workflows that we are starting with at Mary Washington, and Deb will tell you about all the interest that has been simmering and actually coming at her since the launch of this program. But these are the workflows that Mary Washington is starting with. And can you just walk us through these workflows?
Sure. I'm going to have to turn to face the screen a little bit. So, of course, admission is a given. So we're going to have the virtual nurse doing any type of admission for any patient, develop that plan of care, patient education. So each one of these, really and truly, we have done a workflow for. So it's great just kind of thinking, and we have nursing staff, nurse educators, everybody at the table to help us with these. And the quality indicators, like we talked about like a few minutes ago, what are key performance indicators. We also wanted to do workflows around those. And then discharge and any type of code situation. So if a patient's experiencing a stroke or a medical emergency, how will that virtual nurse help? Because they're going to be the ones that are going to be the scribe, being able to call physicians or other key players while they're in the midst of that. So that way the people at the bedside can remain hands-on. Let's see here. Downtime procedures is huge. What happens if we do lose technology or, the internet, that type of thing. And then handoff between virtual nursing in the virtual command center, because we are going to have a virtual command center. So how will those nurses hand off to each other so they can pick up really quickly and continue on? But there is, as Heidi said, there's so many more that we want to do. Rounding, for example, is another one on my list that these nurses will also be able to round on patients, and there's just going to be many, many more. But at the same time, I'm getting a lot of interest from other disciplinaries, of course, to want to use this technology. So pharmacy is a good example. They're already like, let me be at the table, because they want to be able to do their consults right from the pharmacy instead of having to come up to the units, go room to room. They can stay down in the pharmacy, do these interviews with the patient, do the education and teaching, and never have to leave. And that way actually be able to do more patient interaction. So that's really, really exciting. And then I have the diabetes educator that was right behind her. The wound care nurse is like, oh, I could do this. So it's just sparking a lot of more interest, but I'm just being very careful and said, we're getting the nursing part up first, and then we'll circle back around and do the other workflows.
Great, thank you. I have one last question. How are we doing on time? I think we're doing okay. So when we are doing a practice change again, changing workflows, changing the way we deliver care, I think early on in the virtual nursing, and I think we're starting to overcome this, but there was a sense of the current bedside nurses having that ownership of the patient, and that they're not understanding how this person could come in and help them with their tasks in their day. So to accomplish this the right way does take a lot of communication and trust. And so can you describe how your organization has already started down the path? And if you look at the list of the stakeholders that attended the very first meeting we had, I knew they had it right. So if you could just walk us through your stakeholders and how you plan on onboarding and really gaining that trust between both the clinicians within the walls of your hospital and the community as well.
Sure. So, right from the beginning, yeah, we've had everybody at the table. And I mean, like, as she said, everybody at Discipline, because it does really, this virtual concept affects so many people. But we really want to focus on the onboarding. Our plan for right now, as I said, we're going to start making offers by next week after we finish the interviews this week. But we have about a 3-week plan where they will actually be on the units where the nurses are, or where they're going to be helping, the bedside nurses. So we're going to really ingrain them. Every nurse is going to know their virtual nurses, who they are and what they can do, because I do think the trust factor is huge. Since we had the EICU already, they heard, how that runs, but we really want everyone to know that these are our nurses, they're there for you, and they're going to do, be there for them at any time. And so one of the other key stakeholders that we had right from the beginning was public relations and marketing, because they've been there in every meeting they come through, the workflows or even the scope or anything of any of the development meetings that we have, because they have been really good to making sure that communication internally and then externally is being done. And so they like to hear anything that's going on so they can tailor their communication and make sure that the internally from the environmental worker that's going to clean the patient's room understands why that video monitor is in the room and who that person is, so they can, if they get asked, they are just as much as aware as the nurse or the physician is. So it has really been a true collaboration.
That's excellent. Like I said, very exciting going through this process with Deb and her team. And I think we have a few minutes now for questions if anyone has any questions for Deb. And I can't see, so someone's going to have to help me with hands.
I have one, just real quick, actually a couple. Do you get special consent from the patients in order to have the video in the room?
No, we're not. We're going to consider it as part of the treatment team, so no. No, we're going to have it 24/7. So we're going to have a ratio of nurses during the day and nighttime. Mm-hmm.
Okay, and then the last question is, the nurses that you're hiring to work virtually, will they be 100% virtual, or do your inpatient staff rotate to the virtual role as well?
No, we're hiring a separate team, and it's going to be virtually, but it's going to be on our campus. We have making a virtual command center where they'll be housed. And the reason I went that route is because I thought it was beneficial to have a nurse that's sitting beside another nurse. So if one nurse is tied up doing an admission or discharge and a nurse needs help or another patient care need, that nurse can fill in if they're not busy right at that time, or that type of thing, so they can feed off each other. That's why I went with that model instead.
Just one more question. We're running out of time.
Oh, sorry.
Well, I'm going to make it a two-part question then. Have you decided on a ratio of virtual nurse to patient? And as the virtual nurse is doing their shift, are they focused on all of these areas for units? Do you have it broken out, say, one nurse is focused on just the education, or, just trying to understand a little bit of the kind of assigning of the work?
Gotcha.
And again, the ratios, please.
Sure. And full transparency, this is where we're starting with. So during the day, it's going to be a 1:15 ratio for day shift, and then nighttime 7P to 7A is going to be a 1:20 ratio. And we might adjust that, who knows, but that's just our starting point. We're being very agile by this. We're going to see how it goes, set metrics, and the whole team knows that we can pivot very quickly. But what we're going to do is they'll be assigned those 20 patients. So within those 20 patients, and that's why I really wanted the nurses to be together, because that 20 patients, maybe they don't have a lot of discharges or admissions that day. Maybe they're more heavily on education and rounding and looking at quality things and working with that bedside nurse. We just have so many novice nurses, as I'm sure you've heard over and over, and if you're in health or in a hospital now, that we just need that support, and that's what we keep hearing over and over from the novice nurses. So if they can spend more time working with a nurse and being that coach or mentor or just a resource, then let's give it to them. But we're just assigning them based on those ratios. Those are the rooms that they will have, and that's part of the workflow too that we're working on.
I want to sneak one more comment in because I think it's a great idea. So and there may be times when the new nurse doesn't want the patient to lose trust in their ability by maybe not seeming like they know what they're doing. So Deb's team, if it's a certain procedure or something that they have on their LMS system, the preceptor and the new nurse will go to the desk, pull that up, go through that before the new nurse is going into the room, so that that nurse has more confidence going in, and the virtual nurse can still go ahead and virtual and camera in that room, but they're doing it outside of the room to get them ready so that they look like they know more what they're doing in front of the patient. So I thought that was a really brilliant idea. So. That's it.
Thank you, everybody.
Thank you all.
Thank you, thank you.